Well, good afternoon, everyone. My name is Alberta Noonan. I'm from the New England QIN-QIO, and I will be your moderator for today's webinar, Understanding the Updated Blood Pressure Guidelines, Partnering with Patients Better Control. Before we get started, I want to review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end of the presentation. At that time, I'll provide you instructions on how you can ask a question over the phone. You can also pose a question in the chat box throughout the presentation. Please make sure to send your questions to all participants. At this time, I'd like to turn this over to Lisa Neff. She's the Community Health Director from the American Heart Association in Connecticut.
Thank you, Alberta. Today, thank you for joining us this afternoon. I'd like to introduce our three panelists that we have joining us today: Dr. Harvey Kramer, Lakin Bartowski, Jennifer Gilbert, and Taylor Edelman. They will be running through the various topics of our discussion about partnering with patients today, with our objectives being to understand the new blood pressure classification system, understand how to navigate free evidence-based resources from the Target BP website, and also be able to use an evidence-based protocol to guide the way you and your team assess and treat people with high blood pressure. I would like to refer everyone to the individual panelist bios that are on the website today. And with that, I would like to turn it over to Dr. Harvey Kramer.
Thank you very much, Lisa. Good afternoon, everyone, and welcome. This is a very exciting time in hypertension as we have new guidelines to help guide us in the clinical practice of treating people with possible hypertension or established hypertension. The guidelines, as I'm sure many of you know, were published actually last November, and they're entitled 2017 Guideline for the Prevention, Detection, Evaluation, and Management of High Blood Pressure. And that sounds like a mouthful, but the point is that it is really meant to be a very all-encompassing and thorough guideline to the clinical practice of hypertension. The two main organizations involved in developing this guideline were the American College of Cardiology and the American American Heart Association, but these guidelines also have the imprimatur or seal of approval of 11 organizations listed at the bottom of the slide. I won't go through those, but the point is this has widespread approval. This next slide reminds us of the fact that the previous guidelines had been published in 2003, so there was quite a hiatus between the publications of the former guideline and this current update. And you'll see in this slide called Scope of the Guideline that this guideline is designed to be quite comprehensive but succinct, and I laugh because succinct is encompassed by 122 pages of the guideline. The guideline incorporates some new information at the bottom of this slide says, including the use of office-based blood pressure relationship to cardiovascular disease, the use of home and ambulatory blood pressure monitoring, telemedicine, and various other areas. While a number of different issues are addressed by these guidelines, there were four what are referred to critical questions that were raised and answered in the guidelines by the authors. And those include, is there evidence that self-directed monitoring of blood pressure and or ambulatory blood pressure monitoring are superior to office-based measurement for preventing adverse outcomes and achieving better blood pressure control? Secondly, what are the optimal blood pressure targets in antihypertensive therapy? And thirdly, in adults with hypertension, do various antihypertensive drug classes differ in their comparative benefits and harms? And lastly, in adults with hypertension, does initiating treatment with antihypertensive pharmacologic monotherapy or one drug versus initiating therapy with two drugs simultaneously make a difference? And we will very briefly address that at the end, and it is covered in the guideline. This next slide just illustrates the point that by virtue of our time limitations today, we really are going to only cover the highlights of the guideline, and I refer you to the original publication itself for further details. This next slide shows the new blood pressure classification, and this really is a substantial change from the previous classification. Normal blood pressure had been and remains less than 120 systolic and less than 80 diastolic. No change, as I said. But what previously had been referred to as pre-hypertension, which was previously defined as somewhere in the systolic range, for example, between 120 and 140, has been eliminated and now has been subdivided into, number one, elevated blood pressure, which is defined as 120 to 129 systolic and less than 80 diastolic. And now, stage 1 hypertension, which is defined as 130 to 139 systolic or 80 to 89 diastolic. Previously, high blood pressure or stage 1 hypertension was defined as the systolic blood pressure over 140. So this bar has been lowered, if you will. Stage 2 hypertension is now defined as 140 or higher or 90 diastolic or higher. And a new definition called hypertensive crisis is now defined as 180 systolic or higher and or higher than 120 or higher diastolic. So normal is less than 120 over less than 80, elevated 120 to 130 over less than 80, and high blood pressure greater than 130. This next slide shows on the right-hand panel in blue that under the previous definition of a blood pressure elevation of 140 over 90 or greater, approximately 32% of adult Americans had high blood pressure. That's approximately 75 million Americans. Under the new definition, or the middle blue panel or blue column, the 130 over 80 or greater definition, approximately 46% of adult Americans are felt to have high blood pressure, and that has increased the number from approximately 70 or 75 million to about 103 million individuals. And you'll see that in the columns below that as the age groups get larger, the percentage of people at a given age having high blood pressure, of course, gets greater. No surprise there. This next slide shows in the right-hand column that the blood pressure goal for hypertension is less than 130 over less than 80 in all of the groups. Previously, the blood pressure goal, recall, was less than 140, except in two particular groups, individuals with diabetes mellitus and individuals with chronic kidney disease, where the goal was less than 130. But now it has been adjusted to be less than 130 over less than 80 for all individuals. One other significant change here is that under general in the third line there, you'll see that older persons, they define that as over 65 years of age, non-institutionalized, ambulatory, community living, have a blood pressure goal of also less than 130. Previously, for example, individuals over 80 years of age were felt to have a blood pressure goal of less than 150. So this is also a very significant change. This next slide, and excuse the small print, the details aren't important here, but I just wanted to illustrate the point that from this publication from the Journal of the American Heart Association, from the Journal of the American Medical Association, published in 2016, this was a sub-study of the SPRINT trial that specifically looked at individuals over age 75, over 2,000 of them, and concluded that individuals at that age treated to a more aggressive blood pressure goal, namely less than 120 compared to a less aggressive goal, less than 140, did better in terms of the aggregate outcomes of cardiovascular events and also did better from a total mortality point of view when they were treated at a more aggressive goal. And the risk in terms of all groups was no different in the more aggressive rather than the less aggressive group. So this provides some significant substantiation for a more aggressive approach to treating even the, quote, elderly, in this case over age 75, and in our guidelines over age 65, to a lower blood pressure than had previously been recommended. An editorial that accompanied a recent article published in JAMA to address some of the criticism of this guideline that, oh, these guideline numbers, especially in the elderly, are too aggressive, makes the following point, and I've highlighted it in yellow at the bottom. And that is that the problem here is not the result of rigorously developed guidelines, which these guidelines certainly are, but rather is inherent in the high prevalence of unfavorable cardiovascular risk factors. Patients and clinicians need to focus their attention where it belongs, namely on the promotion of healthy lifestyles, prevention of the risk factors in the first place, and only when needed, use drugs to reduce cardiovascular risk following evidence-based recommendations. This slide, again, let's not get caught up in the details, but states something that's very important that we take for granted, but that we really do need to pay particular attention to, and that is the proper and accurate measurement of blood pressure. I know that in my own office, very often we are guilty of transgressions here in terms of our technique, and it is so important that if we're going to accurately assess blood pressure and evaluate and treat it, that we take the blood pressure properly. On the left-hand column, you see here, step 1, properly prepare the patient. So, for example, the patient needs to be sitting in an office chair with feet on the floor and the back supported. When we put the patient on an examination table, again, which I'm guilty of in my own practice, their feet are dangling and their back's not supported. That will lead to an increase in the blood pressure over what it would be if they were doing it by the proper technique. The patients also should have their blood pressure checked on their bare arm rather than through a heavy flannel shirt, for example, or a sweatshirt. Those are just a couple examples. On the left side, also step 2, you want to use proper technique. Again, details are given here. Number 3, take the proper measurements needed for the diagnosis and treatment of the elevated blood pressure, hypertension. Step 4, properly document it. Step 5, average the readings. You really should take more than one reading, and if you're talking about white coat hypertension, you need to take at least 2 readings over several visits in order to help establish that diagnosis. And of course, step 6, provide blood pressure readings to the patient, and they will become an ally in the treatment and evaluation of their hypertension. You can see here on this slide that the American Heart Association and American College of Cardiology now give a 1A, or very high level of recommendation for recommending out-of-office and self-monitoring of blood pressure. And this is something that really is getting significant emphasis in these new guidelines. Out-of-office blood pressure medicines are recommended to confirm the diagnosis of hypertension as well as for titration of blood pressure lowering medication. And keep that in mind, please. You'll see here that if you're going to do that, blood pressure is defined as 4 different types, if you will. Normal blood pressure or normotensive, of course, normal blood pressure both in the office setting and out-of-office or home setting. Sustained hypertension, elevated blood pressure both in the office and non-office setting. White coat hypertension at the bottom, which of course is defined as high blood pressure in the office, but normal blood pressure out of the office. And something that is relatively newer, MASH, also sometimes referred to as reverse white coat hypertension, where the blood pressure in the office is normal, but the blood pressure out of the office, in fact, is elevated. And that carries a prognosis that's similar to sustained hypertension. So it's important to be able to identify that, and it requires out-of-office blood pressure medicine to do that. This slide, which is lifted directly from the guideline, talks about detection of white coat or MASH hypertension in a patient not on drug therapy. And again, the point here is that in order to adequately diagnose white coat hypertension or diagnose MASH hypertension, you need to be able to take the blood pressure, obviously, not only in the office, but also out of the office. And there are 2 ways to do that. One is, of course, with the patient having their own home blood pressure machine, which does need to be verified for its accuracy and then reviewed with the patient, or with a 24-hour ambulatory blood pressure monitor, which can be provided to the patient. And depending on the results of the algorithm here and the patient's home versus office blood pressure, you can establish whether the patient does or doesn't have sustained hypertension, white coat hypertension, or MASH hypertension, or ideally not have hypertension at all. And depending on what happens, then you can establish what the proper mode of therapy should be. You can see here in this slide that A normal blood pressure, we've already talked about, is less than 120 over less than 80. But you'll see here, as you go down the first column on the left, as your clinic blood pressure increases, the corresponding home blood pressure monitor numbers are actually a bit lower. And you'll see also that the nighttime blood pressure should be lower than either the home blood pressure monitor during the day or the clinic blood pressure, to account for the fact that normally there is this entity called a nocturnal dip, where you should have approximately a 10 to 20% drop in your blood pressure at nighttime when you're asleep. So it's important to understand these definitions if you're going to use out-of-office and ambulatory blood pressure monitoring. On the right side of this slide is the algorithm for how to treat and follow up people with different blood pressures, including normal, elevated, stage 1, and stage 2 hypertension. The blood pressure is normal. They're recommended to be evaluated. If the blood pressure is elevated, they be
Dr. Kramer, if you can hold on for a second, we're getting a lot of feedback, so please make sure that you have muted your phone line. Dr. Kramer, I have to actually unmute all the lines and then remute them, so if our speakers, if you can unmute yourselves again once I do this, stand by for a second. Again, I got to unmute everyone and then remute everyone. So hold on for just a second.
The leader has unmuted your line. The leader has muted your line. To unmute your line, press #6.
Thank you. I hope you can hear me again without the feedback.
We can hear you much better, Dr. Kramer. Thank you. I apologize for that.
You. So continuing down the right-hand column here, if you have stage 1 hypertension and you assess your 10-year risk, which is a new part of the guideline, using this atherosclerotic cardiovascular risk disease calculator, if you either have vascular disease or chronic kidney disease or diabetes, or a risk of over 10%, then you're recommended to be treated not only with lifestyle intervention for elevated blood pressure or high blood pressure, but also with drug therapy. Whereas if your risk is less than 10% and you don't have these clinical markers, then you're recommended to be treated with healthy lifestyle and be reassessed in 3 to 6 months. And that additional 25 million Americans identified by this new, more aggressive definition of hypertension, it's felt that the majority of these individuals will not have established cardiovascular disease or diabetes or chronic kidney disease and will have a cardiovascular risk of less than 10%, so that they will need to be treated with lifestyle intervention, but not with drug therapy. Again, that's not all, but that's the majority. And patients who are put on drug therapy are recommended to be reassessed after 1 month to see if they're at goal, and if not, have their medication and lifestyle regimen further up-titrated and reassessed again in 1 month. And after they're at goal, then be reassessed subsequent to that in 3 to 6 months. If they have stage 2 hypertension, further down on the column on the right-hand side, again, healthy lifestyle, which is part of every individual's treatment for high blood pressure, as well as 2 blood pressure-lowering medications, either simultaneously or in sequence, and then reassessed in a month, and subsequent to that, depending on the degree of control. The next slide just reviews for you what I think you all know, and that is recommendations for non-pharmacologic interventions, including weight loss. A healthy diet, DASH diet or dietary approach to stopping hypertension is only one of a number of diets, Mediterranean diet being another that's addressed in the guidelines. Salt restriction, potassium supplementation, increased physical exercise, and drinking no more than 2 for men and 1 standard alcoholic beverage per day for women. Choice of initial medication. There are 4 first-line agents, thiazide diuretics, especially chlorothalidone, calcium channel blockers, ACE inhibitors, and ARBs. You'll notice that beta blockers are not considered first-line therapy for blood pressure. They're certainly in the list of potential options, especially for compelling causes, cardiac arrhythmias, post-MI, things of that nature, but it's not a first or even second-line therapy under other circumstances. This next slide shows that a Class 1 indication is initiation of antihypertensive therapy with 2 first-line agents of different classes when the blood pressure is more than 20 systolic or 10 diastolic above target. And Class 2A indication is you may start either with a single antihypertensive drug in stage 1 hypertension and subsequently to up-titrate as needed to achieve blood pressure control. In adults with hypertension, this states that dosing of antihypertensives once a day rather than multiple times may improve adherence to the regimen that you have, and using combination pills rather than multiple free individual components may also help improve adherence. And then coming down the home stretch here, it's important to keep in mind that we need to not only treat hypertension as a cardiac risk factor, but address other cardiac risk factors that your patients may have, and when appropriate, screen for secondary causes, again, addressed in the guideline. A team-based approach is recommended, so it's not only the healthcare provider, physician, nurse practitioner, etc., but also nurses, medical assistants, pharmacists can all be of tremendous help here in the team approach to getting the patient's blood pressure identified and controlled. And last slide here, this is the sequential flow chart for management of hypertension. And you'll see it starts with measuring the office blood pressure accurately. We take it for granted, but it's so important. Detect white coat or mass hypertension appropriately using ambulatory or home blood pressure monitoring. Evaluate for secondary causes when appropriate. Identify target organ damage. Introduce lifestyle interventions, which we briefly discussed. Identify and treat to treatment goals, of course, and use the ASCVD risk estimator to guide blood pressure threshold for drug therapy, and align treatment options with comorbidities, and account for age, race, ethnicity, etc., which does make a difference on which drugs you may pick, for example. Initiate antihypertensive pharmacologic therapy only when appropriate and necessary, and ensure adequate follow-up, ideally with a team-based approach. So I think with that, I will leave this and turn this over to our next speaker, who is Lakin. Lakin, I'll pass the baton to you.
This is Lisa Neff. At this time, we are going to open up a poll regarding practice assessment and how well do you partner. On the right hand of your screen, you will see poll questions. You may select multiple answers. A, engage patients using evidence-based collaborative communication strategies such as teach-back. Encourage patients to self-manage using self-measured blood pressure. Direct patients and families to resources that support medication adherence. Promote adoption of healthy habits and connect patients with resources that can help. And foster specific lifestyle changes that can prevent and help manage high blood pressure. Again, you can select multiple answers. This is a practice assessment from the Target Blood Pressure website. At this time, I will also remind folks to keep your lines muted. And I will turn it over to Lakin Barkowski from the American Medical Association.
Wonderful, thank you. We'll give you just a few seconds to go ahead and turn in those poll results. And don't forget to press the submit button after you've chosen on the bottom right.
Yeah. Hey, Lakin, it's Morgan. Do you want me to try and mute everyone again, since some folks are still unmuted?
Yeah, Morgan, that would be great if you wouldn't mind. Thank you.
Okay, so again, bear with me. Participants, please do not unmute yourselves when you hear the command, because we are still getting a lot of feedback. So.
The leader has unmuted your line.
Are they able to answer the question?
The leader has muted your line. To unmute your line, press pound 6.
How do you answer the question?
Hi, we just had somebody asking about questions. Your phone line is unmuted, and unfortunately we cannot mute you, so please use the manual mute button on your phone or press *6 to mute yourself.
All right. Well, it looks like we've got our answers in. It looks like quite a few of you are doing great work and partnering with patients, and that's really a great segue into our topic today that we'll be discussing. So I'm Lakin Barkowski. I am a registered nurse. And at the American Medical Association, I work as an improvement advisor, and a large part of that role is helping practices to implement the Target BP Improvement Program in efforts to improve their blood pressure control. I have no disclosures to share with you today, and today I'll be talking about that Target BP Improvement Program and then doing a deeper dive specifically into our Partner with Patients component of the program. But before we go any further, I just really wanted to quickly discuss Target BP. So the Target BP initiative is headed by the American Medical Association and the American Heart Association, and it has 3 specific aims. The first is to be a national call to action to motivate those in the healthcare space to really prioritize blood pressure control. Secondly, we want to nationally recognize those that participate and those that are able to achieve higher levels of blood pressure control. And our third aim is to provide evidence-based resources that make it easy for practices to implement the improvement program that we have as a part of Target BP. So this improvement program is built around the MAP framework, and MAP stands for Measuring Blood Pressure Accurately, Acting Rapidly to Manage Uncontrolled Blood Pressures, and Partnering with Patients, Families, and Communities to Promote Self-Management. And through our work, we've learned that all 3 of these components are really critical for blood pressure control. You need the accurate measurements so providers trust the readings that they're getting and feel comfortable acting rapidly to manage uncontrolled hypertension. And once that treatment is started, you need to partner with patients to promote adherence to treatment and also promote their engagement in the management of their hypertension. We present this MAP framework to physicians and care teams in the form of 3 easy-to-use checklists, one for each component of MAP. And on this chart, I really want to focus your attention in on the second and third columns of this chart. These areas describe the aims and the action steps that we take in each component of MAP, which I'll break down for you quickly. So you'll see our aim and measure accurately is really working to obtain blood pressures that are accurate and representative of the patient's true blood pressure, which is what their blood pressure is outside of the clinical setting over a long period of time. And in order for us to make strides in that area, we work on improving blood pressure measurement techniques, which includes properly preparing the patient, properly positioning them, and then also performing accurate measurements. We also recommend performing confirmatory measurements when the initial blood pressure is high. For the Act Rapidly portion, we're really working to implement evidence-based protocols to diagnose and treat hypertension and reduce clinical inertia. So in order to do this, we recommend use of evidence-based treatment protocols to guide treatment and also increasing visit frequency until the patient's blood pressure is controlled. And finally, in partnering with patients, we aim to engage patients in healthy lifestyles and self-management of their blood pressure. So with this, we recommend using evidence-based communication strategies to engage patients, providing patients with information on diet and lifestyle changes they can make to improve their blood pressure, and also recommending self-measured blood pressure monitoring. And as a result of participation in this program, we expect to see changes in your control rate and changes in your patient's systolic and diastolic blood pressures. Through our work, we also did identify that in order to be successful, there are some cross-cutting requirements. So sites need to have leadership that is engaged in the work and supportive of the work. They need to have staff that are committed to the program and that work together as a team to implement it. They need to have tools that make it easy for them to implement this program, which is one of our aims of the Target BP program. And lastly, they need actionable data to be able to gauge their performance and sustain the changes that they make. So we've had the privilege of working with various practices across the country and found that this program is highly effective. So a formal program evaluation we conducted in South Carolina. We worked with a residency practice there that had a baseline control rate of 61.2%. After they implemented the blood pressure improvement program for 6 months, their blood pressure control rate rose to 89.9%. After that first pilot site, we worked with 16 additional family medicine practices, and their blood pressure control rates rose from 66.1% to 74.8% in just 6 months. So this is really a program that works, and we hope that if you haven't already, you partner with us to implement it in your healthcare setting. So now let's go ahead and dive deeper into the Partner with Patients component of our program. And in this portion, we really discuss collaborative communication, non-pharmacologic interventions, strategies to promote adherence to treatment, and self-measured blood pressure monitoring. So on the screen here, you'll see some evidence-based communications your practice can implement. And we'll go ahead and talk through some of them, starting with open-ended questions. So as you likely know, open-ended questions are questions that require more than just a one-word answer like yes or no. With these types of questions, we're really trying to elicit information from the patient that we can use to determine what's important to the patient, what motivates them, and what kind of barriers they're facing. So an open-ended question we could use to determine medication adherence is, how are your blood pressure medications working for you? If we do suspect non-adherence, we need to be sure that we stay non-judgmental when we're communicating with patients, because if they feel like they're being scolded or judged, they may not be as willing to openly provide information to us. So we should try to determine possible reasons for non-adherence and work with the patient to determine a plan that they feel confident they can adhere to. So one way that we can discuss adherence barriers that patient may be facing is that, I know taking medication can be hard. Tell me about some of the challenges that you've been facing. Now let's say your patients may have been missing some doses of their medication. You could recommend that they start using a pill box, but if the patient's issue is that they're having difficulty getting to the pharmacy when their refill is ready, or they're facing some other barrier, a pill box really won't help with that. So instead, we could say something along the lines of, what do you think would work for you, or what has worked for you in the past? And this really encourages the patient to start thinking of solutions that may help address the specific barriers that they're facing. Patients need to feel confident that they can adhere to their care plan, and we should work with them to determine what motivates them, what they feel they can do to improve their blood pressure, and once their plan is in place, we should check with the patient to see if they feel confident that they can adhere to their plan. We can also work with them to try and proactively identify some barriers that might present themselves and discover some solutions that we can put in place to help address those. Before ending a visit, we should really be sure that the patient fully understands the information discussed during the visit and has no questions about the plan. So to get this information, a line you could use is, we discussed a lot of information during today's visit. Tell me what you're going to do as a result of today's visit. And that gives us an opportunity to hear information from the patient and determine if there's anything they may have missed, or it's also an opportunity to address any questions they might have. So really with evidence-based communication strategies, the main point is that the way that questions are posed and the way that they're delivered can go a long way in allowing us to learn more about our patients and work with them to make plans that are specific to their needs and that they feel confident that they can adhere to. The next focus of Partner with Patients is educating patients on non-pharmacological interventions that can help them improve their blood pressure, and if possible, connect them to some resources that can help them incorporate these lifestyle changes. So on the screen, you'll see what we'll be talking about, those 6 items, and let's go ahead and start with weight loss. So of course the goal would be to get the patient to whatever body weight is most appropriate for them, but this may not be feasible for all patients. So even losing 1 kilogram can help them lower their blood pressure. Actually, according to research, you can expect to see about a 1 millimeter drop in their blood pressure for every kilogram they lose. The next intervention is a healthy diet. And the DASH diet, which stands for Dietary Approaches to Stop Hypertension,
has the most evidence behind it in regards to its ability to lower blood pressure. So this diet really focuses on eating fruits, vegetables, whole grains, low-fat dairy products, fish, poultry, beans, seeds, nuts, plant-based oils, and it recommends limiting things like salt, sweets, added sugars, and red meat. And by sticking to a diet like this, an individual with hypertension can see up to an 11-millimeter drop in their systolic blood pressure. The next is reducing dietary sodium, which can be extremely tough in our country. But helping patients understand food labels and what their goal intake should be, and providing them with some tips on how to lower their sodium intake can be really helpful in this area. So ideally, individuals should consume less than 1,500 milligrams of sodium a day, but again, that can be a challenge. So aiming to at least start by reducing their current intake by 1,000 milligrams a day can be a place to start. So by limiting their sodium intake, a patient with blood pressure can expect to see about a 5 to 6 millimeter drop in their blood pressure. The 2017 guidelines recommend enhanced potassium intake, and the recommendation is to have patients consume 3,500 to 5,000 milligrams per day of potassium, preferably through their diet. And with that, patients with hypertension can see about a 5 millimeter drop in their blood pressure. Of course, increased potassium intake is not appropriate for every patient. So like all other recommendations, this should be recommended on a case-by-case basis. The next intervention is physical activity. So 90 to 150 minutes of aerobic activity is the recommended time per week. And with this, patients with hypertension can expect to see about a 5 to 8 millimeter drop in their systolic blood pressure. Dynamic and isometric resistance exercises can also help to improve blood pressure, and individuals can expect to see about a 4 to 5 millimeter decrease in their systolic with these types of exercises. And the last intervention is moderation in alcohol intake for those who do drink. So for men, that means no more than 2 drinks a day, and for women, no more than 1 drink a day. And individuals with hypertension who implement this moderation can see about a 4 millimeter drop in their blood pressure. Our next focus is to implement strategies that promote medication adherence. We know that medication adherence could be an issue for patients, so putting whatever we can in place from a clinical standpoint to help them adhere is really important. So we should always educate patients on how to use their medications, why it's important, and what effects we expect to see from them taking their medication. We should also instruct patients to give us a call if they're experiencing side effects instead of just stopping their medications and us not finding out about it until the next visit. And as a care team, we can try with the patient to proactively identify any financial barriers that might prevent them from being able to afford their medication. But luckily, many blood pressure medications are available in generic form, which can help alleviate some of that cost burden. Whenever possible, we should try and give patients medications that only have to be taken daily. But if the patient does have to take multiple medications, we can recommend single pill combinations just to try and minimize the number of pills that the patient has to take a day. Also, providing patients with 90-day prescriptions can be helpful because it decreases their need to go to the pharmacy and can alleviate some barriers if there are barriers in place in regards to that. The last thing can be reaching out to patients just after they've started a new medication or they've been starting on a new dose. And this is a way just for us to check in and see if they've in fact started the recommendation, if they're taking it as prescribed, and also identify any issues with the medication early instead of finding out about it at the next visit. So the last area of focus we'll touch on today in regards to partnering with patients is self-measured blood pressure monitoring, or SMBP. And really, in order for SMBP to be beneficial, it's best when it's paired with clinical support, and there's a process for the provider and the care team to get those readings back from the patient so they can use them in clinical decision-making. And as Dr. Kramer mentioned, SMBP can really help improve diagnostic accuracy because it gives us a more complete picture of the patient's blood pressure. So it can help us identify those with sustained hypertension, can help us identify those with masked hypertension or white coat hypertension. And research has shown that therapy guided by home blood pressure measurements compared to usual care based on office blood pressures led to significantly more patients achieving blood pressure control and larger reductions in blood pressure. And SMBP can also be helpful because it offers the opportunity to assess treatment effects at different times of the day over an extended period of time instead of getting a single snapshot when they're in the office. And it can also help to promote adherence to therapies because when patients self-measure and they're following their treatment plan, they're able to see the improvement in their blood pressure. But they'll also see their readings start to get worse if they stop taking their medication or stop following the recommended treatment, which we hope gets them back on track with following their treatment plan. So again, that was just a very high level of our offerings and our partnering with patients portion of our program. We have a lot of other resources to help you incorporate self-measured blood pressure monitoring into your practice, including guidance on how to start a device loaner program if you're interested in implementing that. That's helpful for patients who might not have a diagnosis of hypertension, and you may be ruling out white coat with them, or for patients who are not able to afford a device. Our newest resource on this website is a video that you can actually use to help your patients learn how to accurately self-measure their blood pressure at home. And all of these resources can be found on our targetbp.org website. So as I already mentioned, I hope if you haven't already that you'll join us to improve blood pressure control. And this table that you see on the screen shows different ways that you can implement the improvement program. That top line is self-directed improvement. So with this model, a healthcare setting would go to the website and the improvement would really be self-directed. They may have access to staff, AHA staff or AMA staff to help with things like registration for Target BP or enrollment in the recognition program, but the improvement work itself is really self-directed. The next level would be self-directed plus some additional support from the AMA, AHA staff. And in this method, the practice may feel comfortable self-directing most aspects of the program, but may just want some additional support on certain components like self-measurement or measuring accurately. So we could provide some support in those areas. And the final level of implementation is practice facilitator guided improvement. And in this method, our team could train an individual identified by your healthcare setting to be able to facilitate the program in your practice, and we would provide that individual with virtual assistance and support throughout that implementation process. And at this time, all of these services are provided at no cost. So just a final reminder on top of that, on top of the SMBP resources that I showed, there's a lot of other resources to help you implement MAP in your practices. So I encourage you to go to the targetbp.org website to take a look at that. So thank you all for your time today. I'll go ahead and turn it over to Taylor and Jennifer now.
Hello, this is Taylor here from Optimist Healthcare. I'm joined by Jennifer Gilbert, who's one of our providers here at Optimist, and we work out of Bridgeport to kind of give you guys some reference. Right.
Hello, everyone.
So first things first, we try to keep it simple, but I'm going to kind of delve into our team-based approach and why we kind of went with that. So we already work off of a PCMH plus model, which, for those that don't know, patient-centered medical home plus model, plus being myself as a CHW, a care navigator, sometimes they call it, or care coordinator. So it's basically a model which provides person-centered, comprehensive, and coordinated care to patients. So it really came naturally that we would take a team-based approach to treating patients with hypertension. So we find that the approach organizes care around patients' needs and provides opportunities for care to be patient-focused by customizing the care to meet their needs. Really, the whole idea is to build on the strength of the care team, which includes, the PCP like Jen, the nurse, the MA, the front desk even, the social worker, a therapist, myself as a CHW, the pharmacist, nutritionist, and et cetera.
That's kind of who I'm referring to when I'm talking about the extended care team here on the slide. And we're really focusing, too, with our organization on behavioral health integration. We do definitely notice the links between stress management, especially in terms of hypertension, and then how that plays into access, meeting with a therapist, and a prescriber as well. And this is really so that the PCP has more time to focus on the complexity of the condition.
Yeah, and just to elaborate on what Taylor was saying, regarding the care team approach, using a team of healthcare workers provides a more thorough approach to obtaining a desired outcome. So in our particular setting, the community healthcare setting, we have limited time with the patient, usually between 15 and 30 minutes, to get all of med reconciliation, history taking, and physical exam done. And this often only leaves 5 minutes or less to discuss disease processes, barriers to care, diet modifications, mechanisms of action for the drugs that they're taking, adverse effects, and frequency and dosing. So just to run over, I know Taylor kind of mentioned who's involved in our care team, but just to elaborate on each person's individual role in the care. The provider identifies hypertension diagnosis and any changes in the current diagnosis. From there, it's up to them to initiate appropriate pharmaceutical intervention, delegate alternative interventions to the care team, and determine the appropriate timing of follow-up. The clerical team plays a role in identifying current active insurance. That's important in our community healthcare setting. Make sure that they have access to as much covered care as possible. And also, believe it or not, recording contact information can be more important than you would think to when you have various team members trying to contact the patient. Our medical assistant screens the patient for all risk factors that may contribute to the chronic disease and kind of compiles the information for the provider so that the visit is more efficient. The nutritionist utilizes his or her time to focus on diet modification and lifestyle changes. The community health care worker focuses on barriers to care, which often include transportation, housing, access to healthy food, compliance with all of their specialty consultations. The pharmacist can play a role in educating med administration, and they may mediate access to high-impact medications due to insurance barriers. And we have at Optimus an RN coordinator who also just kind of reviews everything that the other team members went over. So med adherence, they help the patient understand hypertension as a chronic disease. A lot of our patients have difficulty understanding that. So they really do a good job of going over that with them. And help to outline goals for the patient, maybe short-term and long-term goals. It's always important for the patient to feel like they're getting somewhere and making progress. And there's certainly outside team members who do not deal directly with patients but contribute to patient care. For example, the performance management department who provide the care team with feedback on the outcomes of their intervention. This helps the team decipher effectiveness of intervention and identify areas in need of improvement or change.
One thing I do want to specify is when Jen was talking about the pharmacist is we're actually fortunate enough to have a clinical pharmacist on staff. And so I've actually been on a couple visits with her, to address things like language barrier often, or if there's things about the patient. We have a large patient population that is illiterate or semi-literate, so that can tend to get in the way, especially with medication adherence. So I'm there, again, it's showing the interdisciplinary work that a lot of us as extended care team members do to make sure that we can kind of push hypertensive initiatives and care management initiatives. So when I'm talking about culture of quality on the slide, I'm really talking about population management. I'm talking about things like a data list, a dashboard. Something new that one of our data analysts, Justin, has done is actually provided all of us with a dashboard. And Jen will touch a little bit more on that since it's more specific to what she's doing. So she can address specific gaps in care and even hone in on specific patients if she's not meeting a target goal. Other than that, we really focus a lot on doing huddles as well. So 15 minutes each day, I go and sit with Jen and we discuss the patients that are coming in. I particularly see our high-level patients, which are people that have diabetes, chronic diabetes uncontrolled, hypertension that's uncontrolled as well, and asthma. But obviously for this purpose, we're going to be specifying more on the hypertensive side. And then people often ask us how we got to that plan because it seems like a pretty heady endeavor. And it's true, it's often challenging to get everyone on board when beginning something like this because we often hear, I'm too busy, it's yet another thing for me to do, I don't really understand how it's going to work for me. However, once we selected the champion provider, so Jen in this case, and we began this pilot, we started to gain a little bit of traction. So now the care team realized that having a team-based approach is actually quite timely, collaborative, and it's ultimately empowering for the patient, which is something that we like to focus on, particularly myself, as being a community health worker.
Yeah, I agree with Taylor that staff buy-in can be a difficult one. Everyone's schedules are already busy as it is, and just getting to the everyday tasks that we need to complete is often difficult. So people have developed their own way of providing treatment plans and have found an efficient way, so change is often difficult for them. Our performance improvement department has recently paired with IT to create a new data dashboard that we will all eventually have access to, which is great. This allows us to quickly compile data from Optimus in any format that we want. We can kind of customize it if we want to see our progress company-wide for a global comparison, or we can make it individualized to each provider if someone is, curious about their own personal progress. We can modify the range to look at annual, monthly, weekly, or even daily percentages on performance measurements, and that includes things like hypertension control, screening for depression, colonoscopies, etc. I feel that this tool is going to be extremely useful to our company in instilling healthy competition. I know I've already looked at some of my measures, and I'm only 2 to 3 patients away from meeting goal or exceeding goal. So to me, that's definitely motivating. And I think if the rest of the care team has access to this, they may feel the same way.
Absolutely. So I'm going to move on to the second slide here, which is patient-family engagement and how we kind of handle that. So we engage patients and families in the treatment plan by having the provider initiate a care plan, something that Jen, the provider, will do. So that gets sent over to our nurse care coordinator, who adds interventions, and tweaks it based on the patient's particular situation. And the patient also creates a SMART goal, something that I have on the side there. It's specific, it's measurable, attainable, relevant, and time-based. So that gets set with the patient during a separate nurse visit that we can charge for. So the goals pertain to something that the patient would like to work on, and then we guide them from there. So when it comes to patients with hypertension in particular, many of the goals incorporate a desire to alter their physical activity or nutrition. Although we know the importance of medication adherence, patients often focus on diet and exercise, and although important, it's not really the entire picture. So that allows us to introduce the pharmacist or have the patient meet with the nurse bi-weekly for a BP check, where they're shown how to correctly use their monitor, if that applies in that case.
Yeah, and as Taylor mentioned, we do try to allow the patient to have as much say in their care and the plan of care as possible. It is common knowledge that the more the patient feels they're involved in creating the plan, the more likely they are to adhere to it. So I do have many patients who prefer to avoid medications for various reasons. For some of them it's cost or just personal preference. For me, it's important to explain to them the medical recommendations and indications for using a medication. But if they affirm their desire to work on diet and lifestyle modification, I try to work with them as much as possible. I look for a compromise. I will use dialogue like, okay, I understand what your ideal plan is. How about we compromise on something, and we will have you try diet and exercise for a month and watch your blood pressures at this time. And then try to have them come back in a month and reassess. And oftentimes just them seeing that their blood pressures are not controlled correctly in that way does help them understand why we're intervening with medical intervention as well. There are many cases in community health where the family members are administering meds, checking blood pressures, overseeing diet restrictions. I find in most cases, family members are extremely useful in that they know the patient very well and may have an advantage in delivering healthcare information to that patient in a way that would otherwise be unheard or disregarded. Especially in my geriatric patients, the more the family members become involved, the better. They're more apt to go pick up medications from the pharmacy or prepare low-sodium diet for the patient if they have proper knowledge of the disease.
So a big barrier that we have, probably the biggest one, is addressing non-adherence. And I think a lot of facilities have that issue with patients. So it's common, it's frustrating, so it helps to have a few things at a disposal. However, ultimately, if the patient doesn't engage or participate in our care, then the entire structure does them no good because, remember, it's really patient-centered care. So this is usually where the community health worker comes in to address social determinants of health. So there's social barriers that are impeding their care, things like food, housing, transportation, employment or lack thereof, language barrier, literacy barriers. And as Jen mentioned about cost, we have something at our organization, the 340B program, which allows our patients, uninsured and commercially insured, to have high deductible plans to access medications at a much lower cost. We also are fortunate to have in our community something called Operation Hope. Although they only have a small amount of medications, they do provide free medications to some of our patients, particularly our uninsured patients that hit a certain income guideline. So we often find that if one or more of these barriers exist, the patient's care suffers as a result, right? So CHW is heavily assessed for behavioral health issues. We do a PHQ-9, a GAD-7, a PTSD, and a CAGE-8. So we find time and time again that our population suffers greatly from mental illness, which could have serious consequences on several levels, from keeping themselves isolated and inactive to suspicious of their medications to the point where they're just going to stop taking them entirely. So if the CHW is unable to get through to the patient by addressing the patient's barriers, then they might ask the nurse care coordinator to step in, see if there's an issue on the clinical side. Oftentimes, non-adherence comes in the form of not showing up or showing up inconsistently, which then sets off a cascade of intervention. So I call them 3 times. If I don't hear, I send a letter. And we can even do home visits as well.
Yeah, so I definitely agree with Taylor that non-adherence is one of the most frustrating aspects of our work, for all healthcare workers. I think this is the area that the providers need the most help from their team members, especially, here at Optimist, I definitely utilize my CHW Taylor most of the time. He's the expert as far as handling non-adherence. He's been a crucial team member for me when it comes to contacting patients, identifying recent ED visits, keeping patients notified of upcoming specialty consultations, and eliminating housing, food, or transportation issues. And just as a side note, I think from my experience that the more contact that we have with the patients, the more likely they are to adhere. Just to give an example, Taylor and I were recently working with a patient who unfortunately was still very uncontrolled with his hypertension, but he had probably, exhausted all revenues of resources for this patient as far as trying to get him care, through behavioral health and specialty services and nutrition and et cetera. And unfortunately, the patient kind of fell off of care. And Taylor had discussed with me that we probably needed to discharge this patient from his services from the community health worker. So, it seemed as though this was pretty hopeless for this patient as far as getting him to come into for follow-up visits, et cetera. So Taylor, made one last attempt to send out a discharge letter to the patient notifying that he has not followed up with his appointment, so he will be discharged. And probably about 2 days after Taylor had mailed that letter, I did notice in my lab work that he had gone and done his lab work. So it kind of, you never know how much contact it's going to take to get to someone, but it does make a difference.
Thank you, Taylor and Jennifer. We are coming up to time. I would like to turn it over to Alberta and the WebEx host. I'm sorry we're close to our time.
So thank you, everyone. I just have a few announcements before we end today's call. In the meantime, you could be answering your questions in the chat box, and we will forward them and for follow-up. A reminder that we are now on social media. Visit us on Facebook, LinkedIn, and YouTube. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with a link to the evaluation, as well as a link to the event page on our website. The slides are available on the event web page. Within the next few business days, the recording and transcript of this webinar will also be added. I've put that link in the chat for you again. Thanks again for attending, and have a good day.